Welcome to Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay happy and healthy. So join me as I chat with other Boston children's experts to find answers for you and your family. Hi everyone, and thanks for joining us today. We are going to talk about a topic that many parents probably have a lot of questions about, and that's concussions. Whether or not your kid plays sports, concussions is a hot topic for many of us parents as we're raising our kids. So, as always, let's start off with a question from one of our listeners.
Hi there, I'm Mia. My friend's son hit his head during a soccer game the other day and seemed fine, but it got me wondering, how do you know when a head injury needs a doctor right away? I have two very active kids and just want to be prepared.
Thank you, Mia. That's a really excellent question, and it's a common topic I think that many parents want to know more about. Here today to answer your question and more is our expert, Dr. Michael O'Brien. He is director of the Sports Concussion Clinic here at Boston Children's Hospital. Thank you, Dr. O'Brien, for joining us today.
Thank you. Yeah, thanks for having me.
As we get started, I always love to ask each of our guests a little bit about how you got into the specialty that you're in.
Yeah, I've always been involved in sports as a kid. Quickly realized I was not going to be big enough or good enough to be professional, and fortunately or unfortunately, I was exposed to medical care early. I had a couple injuries, a couple surgeries, and then luckily, as I went through medical school and residency, I found what we call medical sports medicine, which is non-operative sports medicine in the Department of Orthopedics, and just found my niche.
I have found that's probably the most common theme amongst our experts here is that a lot of us get into the field of medicine because we've had our own personal experience, which is really great.
Yeah.
Well, as we dive into our topic today, can you help our audience understand really what is the definition of concussion?
Yeah. The scientific definition of concussion is a rotational acceleration of the head and the brain in the skull. Usually where the head and brain is moving at one speed, it hits an immovable object and the brain kind of rotates or shifts in the skull, and that causes what we call shear forces or stretching forces on the axons, the cells of the brain. In a little more practical senses, it means that the brain cells are injured. Usually it's direct, sometimes it can be indirect, causing whiplash, but usually the brain cells are interrupted in their function. And so depending on what part of the brain is affected, you may have different symptoms, headache being the most common by far. Most commonly, especially in sports medicine, it's a very temporary injury, but it needs specific treatment. And because it's a functional injury, the function of the cells are interrupted, it often does not show up on things like CAT scan or MRI.
What does that really mean versus maybe other injuries of the brain?
A lot of times parents are trying to understand it in a tangible way, and so they're picturing a bruise of the brain or bleeding of the brain. And it's really not. Concussion is not bleeding of the brain. That's something different called intracranial hemorrhage. And it's not a fracture of the bones. That would be called a skull fracture. And it's really not even a bruise that you can see on an MRI and CAT scan. And so while we work it up and while we treat patients, that can be a little disconcerting because a lot of times we're not getting MRIs or CAT scans, and it feels like that should be something that should be done, but we've gone through a lot of research to understand when the imaging is most effective. In concussion, it's really the function of the cells, not the way the structure looks, and that's where this injury can be a little different than other orthopedic injuries.
Speaking in my own experience as a parent who had a child diagnosed with a concussion, it seems like that complexity of the diagnosis probably makes it hard to diagnose. I want to talk a little bit more about diagnosis in a minute, but just to start off with some basics, how common, are concussions in kids?
If you take the entire country, a number that's quoted quite a bit is about 2.3 million concussions, 1% or so for the age 5 and under, and that tends to go up a bit between age 12 to 17, where it might go as high as 6% for incidents of young adolescents getting concussions. My expertise is typically in sports-related concussions. They're not rare, but you wouldn't expect someone to have a concussion. More commonly are other injuries like knee or shoulder or wrist injuries.
Is there a higher risk of sports-related concussions?
I think we end up gathering data on more of the sports-related concussions, and we end up chopping that data into finer pieces, whereas the non-sports-related can be car accidents, assaults, things like that.
Falls.
Falls, right, exactly, accidental falls. And so I think that sometimes gets lost in the data because there's not maybe as much surveillance.
Yeah, and probably not as much grouping of the data together. Are there any populations that are higher risk?
Most certainly, young female athletes seem to be more likely to have concussions, more likely to report the concussions, more likely to have a higher symptom score when they present, and a bit more likely to have a bit longer recovery than their male counterparts in a similar sport. And age certainly makes a difference. The higher rates of concussion are between about age 12 to 17. Then you can break it down by sport as well.
Yeah, so tell me a little bit about that. Yeah, which sports are higher risk? Because I think that's, for me as a parent, I know what I want to know.
Yeah, and I think it's interesting. You can look at it in a couple different ways. The American Academy of Pediatrics and several other groups have made lists of sports and organized them by collision sports, where collision is in the rules, contact sports where you body contact but not collide with a player, and non-contact sports. American football has the highest rate of concussion per hour of participation for the athletes. And that's typically played by male athletes. For female athletes, soccer is the highest rate of injury per hour of participation. Wow. And girls soccer has a higher rate of concussions as it compares to boys soccer. If you look at numbers and say, well, the most likely injury, if I were to get an injury, what's the sport that it's most likely that injury would be a concussion? Cheerleading and ice hockey are actually at the top of the list, which is interesting when you turn the data a little bit and ask a different question.
I was a cheerleader as a kid, so it's good to know.
It is very dynamic, and cheerleading, a lot of elements are like gymnastics, but gymnastics has a bit more sort of an organized stepwise fashion, whereas cheerleading, very artistic, very dynamic, and it seems more, I don't know, in my mind, more creative, where you can just try different things, and the flooring is not the same as gymnastics flooring. So I can see many elements where the cheer teams can have more risk of injury than many other sports. It's really intense and is often year-round, so you see a lot of participation hours.
Then just by that mere fact that they're going to be doing more sports year-round increases the likelihood of having an injury and then being a concussion.
Back to our analogy with American football, that's usually one season per year, whereas soccer, you could imagine increasing that exposure by 4 times, because they may be on their school team, their travel team, their club team, their all-star team, and it's an all year-round exposure, so to speak. The rate of injury per hour is lower than American football, but they may quadruple their number of hours per year.
That makes sense. I mean, the more exposure you have, the more likelihood you could have.
Yeah.
Yeah. You mentioned collision versus contact versus non-contact. It might be helpful to understand that better.
Examples of collision sports, it's legal within the rules to collide with another player. So American football, rugby, wrestling, those are examples of collision sports. Contact sports would be basketball, soccer, for instance, where you'll have body contact, but it's not a collision into the ball carrier, for instance. But it's contact. Oh, it's not only possible, but it's expected. Contact is expected during basketball and soccer. So not to be underestimated for the risk of injury, but it's just a different word that we use, collision versus contact. And then non-contact would be tennis, cross-country, sports like that are even baseball and softball. Typically, in the regular course of the game, there's no body contact or no ball to player contact, although it does happen from time to time.
That's really helpful, I think, for parents who are probably trying to make decisions about which sports they want to support for their kids.
And there are published data to say, okay, this one has this per hour exposure and this one per hour exposure.
The data's out there.
Right, and there's a lot of, even in the sports data, there are folks who are, we always have concerns to say, well, how much is being reported, right? Especially in end of the season, near playoffs. A concern that we've always had is that athletes are not necessarily as willing to speak up. It's always been shown in the science that the female athletes are more willing to speak up and more seems like they're more precise or more apt to report their symptoms, whereas male athletes tend not to. It tends also to be the case that they may not report them as often in high pressure situations, in playoffs or overtime situations where they don't want to come out of the game. And we know also from our science that concussions seem to be sustained more commonly in the game situation as compared to practice situation. So there's a higher rate of injury during gameplay than practice.
You're in the middle of competition. You don't want to get out of the game.
Exactly. And I mean, that may lead into some of our other topics, because when we're on the sideline, whether it's trainer, coach, parent, or doctor on the sideline, it's not typically visible to us if someone got a concussion. It's the rare occasion that the person loses consciousness. Now, that's most obvious to us. We can see that, and everyone will activate the emergency system and will withdraw that patient. They won't return to that same game that same day. That seems obvious, right?
Yeah.
But that's far less than 10% of the cases. I think it's certainly less than 5% of the cases. The majority of the cases are not that obvious to us. They don't have loss of consciousness. If we're looking very precisely, we might see the athlete shake their head or stumble a bit, but there may not be outward signs that we can see from the sideline. So we do rely on the athlete to report to us and say, something doesn't seem right to me. And they're motivated, and they're intense, and they want to support their teammates. So it's a common scenario where they're not necessarily willing, or they may not even recognize the symptoms. And so we may not have that communication, which is difficult.
Yeah, and I also think about how often you see a kid get injured and everyone claps when they get up and they get back into the game, right? So there's also that positive reward too.
A big part of sports is not winning or losing or setting your records, but learning how to be sore and get dirty, get scraped, and push through it. That builds our resilience.
Yeah.
But we also want to temper that and make sure that we're sending a message that it's okay to speak up when it looks like there might be an injury. And so finding that balance is part of growing up, isn't it?
Such a valuable lesson. Yeah. Resilience is good, but not if it's going to put yourself at risk. So got to have that balance. Well, as we talk about that and sort of some of the important things for, I think, parents and kids to know about concussion, what about the myths? I feel like there's a lot of things such as, don't go to sleep if you've hit your head. Can you tell us a little bit about the common myths that you hear?
It's a good question. That's an excellent question. In fact, a large part of my appointments with patients and parents is unpacking a few of the myths and trying to set a plan to say, here's what we're going to do for the immediate management, the next 24 hours, the next 1 week or 2 weeks. So waking the patient up frequently is a little bit more of an older myth or an older approach, and it really has more to do with intracranial hemorrhage. If there's hemorrhage, then if the patient was inpatient, if we were in the hospital, we would wake them up every couple hours and do a neuro check, make sure that there was not any unusual pressure on the brain or anything emerging or getting worse hour to hour. I would say in sports concussion, we look for very specific signs of intracranial hemorrhage. And if we see any of them, we may consider doing an emergency department evaluation and typically a CAT scan. But it's important to minimize CAT scans, which has some radiation. But the first myth we were saying was, what about waking the patient up every hour or every 2 hours? That's typically not what we do unless we see some of these concerning signs. And we'll get to those in a few minutes, I think.
So that's one of the myths, and then thank you for debunking that for me. Are there any other myths that you find yourself having to debunk?
Among the most common is screen time and cognitive effort. We should recognize that reading, studying, or screen time is never going to injure the brain. Now, it may create headache, it will be more difficult, it will take more time, it will be frustrating and take more effort. But the presence of a headache from reading or studying is not dangerous, and that's our first responsibility. I'll tell our fellows, when the patient comes in and we talk about a plan, we have 3 jobs to do. We think about risk assessment, we have to make a treatment plan, and then we'll talk about participation in sports or withdrawal from sports. But our first job is always risk assessment. Again, back to imaging. The imaging is done to look not for concussion, but to look for other causes of headache and things, so fracture or bleed. When we're talking about management, okay, so that's treating and recommending who should read or who should try back to school, the presence of headache is not necessarily a dangerous sign. So we do find ways to say, okay, we're going to get you back into your routine. We're not going to do strictly a dark room and do nothing and no reading attempt until the symptoms are gone. We're going to have to go through a certain amount of symptoms. And that's where we together in the patient appointment, we say, well, this much of a headache is acceptable and this is too much.
But I think the fact that, just using the screen in and of itself is not causing harm, that's important.
Agreed, yeah. So that's the key. It's not doing more harm to the brain. It may be difficult and actually physically not as easy to do. And that's why if we're going to have patients work with any screen time, I want it to be school-based. So we do try to minimize some of the non-school-based screen time just because we don't want them feeling worse from
getting more headache.
Right? Then they can't keep up and make up with their schoolwork. So because we have found the student athletes really get overwhelmed if they miss a couple days, a week, 2 weeks of school, especially junior year or early senior year. Like there's a lot of volume. If they miss a bit, even a week, which seems like a small amount, it's an enormous amount to try to keep up and make up.
Yeah.
So we try to mitigate that.
You're kind of making me think of an analogy. I don't know if this is helpful or not, but you can tell me if I'm spot on or totally off base. Yeah. No pun intended with sports. But I think about treating kids with, a stomach virus. They need fluids, but if they guzzle a whole amount at one time, it's just going to exacerbate the nausea and vomiting. Yeah. And that's not comfortable. It's not hurting them per se, right? They're not going to get an intestinal problem, but it makes the symptoms worse versus just a little bit at a time can keep them hydrated without causing them to have more nausea and vomiting.
I think that's a great analogy. And I'll use an analogy in sports medicine. I'll tell them, look, if you have a knee injury and we put you in this complete knee immobilizer and we don't move it at all, it's going to get stiff and weak. And then we're going to do physical therapy. We're going to move that knee. It's going to be sore. It's going to be uncomfortable. It's going to get tired quickly. That's kind of the analogy. Like we can't keep you in a dark room for too long. Yep. We're going to decondition you. We're going to reactivate with light, non-contact exercise and re-entry in school, reading and studying. It's going to make things a bit sore. You're going to get more fatigable than usual. It's going to be frustrating, but we are going to do that active recovery instead of totally passive recovery, which is what maybe a few years ago we would call cocoon therapy. Sit in a dark room until your symptoms are gone. That doesn't work. No. If they don't get better quickly, we are creating deconditioning, and that can be a problem we have to overcome.
Yeah, other problems that you're creating.
Yeah.
It's really helpful. So now taking a step back, so, my child maybe plays in a sport, maybe something happens, and I'm worried that he or she may have a concussion. What are the symptoms that parents should be looking for? Yeah,
signs and symptoms. Signs might be something we could see, and there's a interesting paper recently that was suggesting that the head shake, if they're shaking their head, we really have to take a quick look. Certainly a sign might be they get up and they stumble. And so me on the sidelines, I'd want that patient to come over. We need to really get into a clear discussion. Did he stumble because it was an ankle pain or he got pushed, or was he feeling unwell, unsteady from after a collision? So those might be what we call signs. Symptoms, the most common would be headache, dizziness, nausea. Then we might even say a third category, concerning symptoms, concerning signs, right? When do we activate a different level of assessment? When do we say, look, this might need to be assessed right now, either in the emergency department or with my pediatrician, or so those would be more like repetitive vomiting, lethargy, or progression where the patient becomes less responsive or not as interactive as we expect. Those would be signs that would alert us and say, wait a minute, we have to escalate this to a different level of treatment or assessment.
And is that because you might be worried there's more than a concussion going on?
Exactly, right? So that's where if we see repetitive vomiting, confirmed loss of consciousness, seizure activity, lethargy, or progression where the patient is not interactive with us, I'm going to look for other causes like intracranial hemorrhage or fracture.
Yeah, so those are the serious symptoms for parents to be aware of.
Exactly, yeah.
That's important to know.
Yeah, those are the three different ways. Again, signs on the side then say this person should be withdrawn. Signs or symptoms that say this looks like a concussion. And then the other ones that are saying, wait a minute, these are symptoms or signs that are we need escalation of treatment.
Yeah. It's really important, I think, for parents to be aware of that too, so that it alleviates some of the anxiety that we have. What should parents or their coaches do when a child exhibits signs or symptoms of concussion out in the field?
Yeah, game or practice, even if it's overtime or playoff, that player should be withdrawn from that contest or that practice and not return to that game if we suspect concussion. And if we suspect concussion, they should be seen and evaluated by a clinician with training in concussion before they're cleared back. Now, the pediatrician they'll have additional training in concussion management, and they may be able to clear back, or experts like us in sports medicine, but it should be a clinician that has seen them, confirmed that their symptoms are resolved, confirmed that they are appropriate to return back to the practices or games. But typically on the day of participation, if it's practice or game, whatever it is, if we see signs or symptoms of a concussion, that player should be withdrawn and not return to that contest or that practice. That they should not return that same day. They should be assessed and cleared before the return. And then if there's escalating symptoms, then escalation of treatment would be they might need to be seen at an emergency department, and they need to have advanced imaging like CAT scan. Luckily, that's uncommon, but we all need to know if our children are participating in sports, we need to know some of those guidelines.
For parents whose kids are in those sports that maybe don't have a medical professional even, at the game or at the practice, and some type of an injury occurs, do you have any advice for parents to help differentiate, whether or not their child may have suffered a concussion in that moment and whether or not they need to escalate care?
Yeah, it does begin with communication with the athlete. So it probably begins even preseason to make an agreement to say, look, if you're not feeling right, if you're feeling headache or dizziness or nausea, and these were not present before the game for some other reason, you need to be willing and make a commitment where you're going to speak up to me or to your coach or whatever it's going to be, because that is the most common way that we identify concussion. Seeing it and me being the one saying, look, I know you have a concussion, I can have to withdraw you, that's the less common. But the athlete that's injured and on the field and in this period of vulnerability where recurrent collisions occur while they're injured, that is the case that patient will more likely escalate their symptoms. That'll be the patient that more likely will have prolonged recovery if they've had recurrent collisions while they're in this, we call it a window of vulnerability, while they've been injured but it hasn't been identified, they haven't been withdrawn, but they're injured and they keep getting more collisions. That's actually the highest concern for me. Believe it or not, the patient with a big, clear injury and loss of consciousness, they tend to do actually a bit better in their recovery, certainly as compared to the one that was not identified. They had recurrent collisions that sort of stacked up on each other before they were allowed to recover, if that makes sense.
Like so many things, it's about communication and educating your child. Having that conversation early on, frequently enough, will help them to hopefully feel empowered to share with you honestly what is going on so that you can have the best outcome. And the other piece that I learned is that, if we can tell our kids that it's better to get you back in the game by reporting it early as opposed to not, because the recurrent injuries can cause a longer term problem and make recovery more difficult. I think that's really important.
Agree. I think they have to buy into it. They have to believe, and we have to have that trust and communication.
So important. We talked about the signs and symptoms, but when a concussion has happened or we suspect it, how is it diagnosed?
Yeah, right now it's mainly subjective, meaning it's not objective. If I have an injury to my wrist, I'm going to do an x-ray. That's an objective test. We say it's either broken or not broken. Concussion is a bit more subjective. We're asking the patients to fill out a survey, a symptom survey. We call it the PCSS, the post-concussive symptom score. It's actually 22 symptoms that are common for concussion, and they will list their symptoms 0 to 6. We're asking them to rate it anything that was different, any symptoms that were present and still ongoing as compared to their general healthy status before the injury. So we generally use the symptom score, and we'll have them in the office or the sideline. We'll do balance testing. We call the BESS, balance error symptom score. We'll do you've seen these silly finger to nose testing, yeah. And we may or may not use computerized testing at different points. Computerized testing is used, or baseline testing, measures these different metrics, and we call that their healthy baseline, right? We'll put it in, file it away. If they get an injury during that season, we may have them repeat that computerized test and then compare those exact measurements to their preseason performance, right? And if they're low in different areas, we would say, well, this looks like it may be evidence of concussion.
How do kids get that?
A team or a league or a school or even our facility, like at Children's Hospital Sports Medicine or at the McKaylee Center, we'll have patients sit and take this computerized test, and it measures immediate memory, delayed memory, reaction speed, motor speed, and once their symptom score is 0, once they can tolerate school and academics, or what we call cognitive effort, and once they can tolerate non-contact exercise, then we may repeat that test again and see, is that objective testing, the computerized testing, as good as their preseason testing? We use those factors to say, well, is this person ready to return to sport, including if it's a contact or collision sport?
Yeah, it's funny, reminding me, my son had a concussion, and they did this test on the iPad, and it was, unfortunately we didn't have a baseline because his injury wasn't from sports, so we didn't know ahead of time. So parents out there, if you have a kid in sports, think about getting baseline testing, because it made it harder to interpret.
Yeah, you can use some of these computerized testing without having had a baseline. Having a baseline is nice because you see that person's personal performance on that same test. And we can manage concussions without it. So I don't want parents to feel too badly if they never had a baseline. But we do use it as a tool, particularly if there's, in complex cases, we find it another additional helpful tool as an objective measure.
Yeah. So it's just putting all of your tools in your toolbox.
And that's the terminology I use. We're trying to build our toolbox, our assessment toolbox, our treatment toolbox, and our knowledge about concussion in general.
Just real quickly, you mentioned the McKaylee Center. Just in case someone's new, can you remind us what the McKaylee Center is?
It's the McKaylee Center for Sports Injury Prevention. So we do research and practical applications. We do treatment plans or plans for the athletes to improve their performance, but our goal is really injury prevention. So we will do things like baseline computerized testing. We'll do concussion programs where we're actually trying to achieve prevention of injuries by improving balance and what we call proprioception. Proprioception is like body control, neck strengthening. The better body control or neck strength we have, we believe there might be less rotational forces or less of the awkward falls. If there's better body control and a young lady goes up for a header for a soccer ball, she may be less likely to either have an accidental head-to-head collision or head-to-ground collision. And for that matter, we're trying to prevent knee injuries and ankle injuries. So our goal at the McKaylee Center is injury prevention. And so we work on strategies like that across many different sports.
Thank you for explaining that. Yeah. So let's talk about that treatment. How do we treat concussion in kids?
The short answer is not really the best answer, but the short answer is rest. But what we've been learning over the last several years in particular is we can't overdo or overdose rest. So when I'm talking to patients and parents, everyone's worried and uncomfortable, and there's complexity with school and sports and playoffs or whatever it is. I think it's best we try to simplify and figure out our goals together. And I'll say, look, we have 3 goals here. We want to avoid collisions until we feel like the patient is fully recovered. We want to minimize the impact it has on school, and we want to prevent or undo deconditioning. Deconditioning can be physical, psychological, social, right? So we want to minimize the impact it has on school. Reading, studying, even digital exposure is not going to be dangerous to the brain, so we can find a way to reactivate, get back to the routine of getting to school, seeing friends, seeing teachers. Maybe not doing full schoolwork right away, but doing with accommodations that we've requested from school for longer time, for deadlines, a different assistance while they're recovering. But still not just abandoning totally, because we find that isolating, doing no schoolwork, doing no exercise. So if they're in a dark room sleeping all day, they're not going to sleep well at night.
Yeah.
If they're an athlete used to working out 2-3 hours a day, stopping all exercise is going to make them actually feel very much worse. So we have to find ways to avoid that. So we will activate light, non-contact exercise, and we'll find parameters of how much exercise we can do in the beginning and in the middle and the end of this recovery. Slowly increase. But we find that adding non-contact exercise is actually very important.
Wow. Yeah, so it's kind of like we want to avoid, the big thing about treatment is to, avoid deconditioning on all fronts of a child's life, really, right? It's social, it's academic, it's physical, to help that athlete get back in the game sort of more quickly and without losing a lot.
Exactly. And that's not easy sometimes. It's like I find that end of sophomore year and junior year, in high school especially, there's a lot of pressure, a lot of volume, not a lot of flexibility.
No.
We find there's more flexibility in the younger kids, grade school, second, third grade, and more flexibility in college. There's more volume, but more flexibility. But I find different ages, different times of their academic career even more challenging.
Yeah, really important.
Yeah.
Okay, so let's talk a little bit more about recovery. I'm thinking about, from my parent perspective, the practical things. So what is the typical recovery time like? And, how do we manage our kids at home, when they want to play video games, be on social media, watch TV? Like, are those things that, I need to limit? And how do I balance that with letting them be on their screens for school?
80% or around that is 2 weeks or less. When you get out to 4 weeks, that'll probably cover about 92% or 93% of all sports-related concussions. When it gets beyond 4 weeks or 6 weeks, then it gets a little more gray in how to predict how long is this going to recover. The general advice for each concussion is to make sure schoolwork is accomplished first, because most schoolwork now at least needs some type of tablet or computer interaction. And luckily, it's not dangerous to the brain, but it sometimes causes eye strain or headaches. And so we want to use any reserve that they have to try to keep up and catch up with their schoolwork. If they're able to do that effectively, then I think they can do additional screen time, even video games, if it doesn't clearly worsen their symptoms, specifically if it doesn't affect schoolwork negatively. Social media, I think, if we totally withdraw them, I think that might add to some of the deconditioning we worry about. So we still want the patients to be connected. We want to have them have their social interaction, but prolonged time on a small screen, especially in a dark room, may just provoke headaches.
Yeah.
And so generally, I do say, look, it's not a fight that you have to say zero screen time. It's just a matter of making schoolwork, especially if that needs screen time, as a priority.
Like everything, it's balancing it out during that recovery time.
Yeah, moderation, putting our priorities, right? Yeah.
It's so hard as a parent.
Of course.
So after, you've gone through the recovery time and, you and your physician and the coach feels like you're ready to return to sports, an average, like how long is that until kids can return?
Well, the total recovery time, again, may be anywhere from 2 weeks to 4 weeks. That would not be that unusual. The stages people talk about is starting with light exercise, then medium intensity exercise, and then high intensity non-contact exercise. What I'll do is we'll have the patients start with light exercise pretty early, and even while they're still having symptoms. They'll do a bit more medium intensity exercise, maybe with sport-specific drills and skills here and there, as long as they're tolerating school and as long as the symptoms are getting better in general.
Okay.
But they won't advance to contact skills and drills until we've confirmed symptoms are fully resolved, academics are tolerated, and exercise is not provoking symptoms.
Great.
So we'll go through these stages, but we'll reserve advancing to full participation or any contact until we see those other criteria.
That makes sense. It's just a stepwise progression. I don't know if it's possible to relapse from symptoms, if you don't take that time that's needed to fully recover.
Exactly. It's a great point. In fact, sometimes we don't talk about that enough. There are times where people do too much. Especially the athletes, they get excited. It feels good to exercise, and their symptoms have been provoked or exacerbated. The good news is that doesn't mean they're injured. They're re-injured. It doesn't mean their brain is re-injured. As long as there was not a new collision, it just means that we've done a bit too much and we've exacerbated the headaches or the symptoms. Then we take a step back, maybe give it a day rest and start with a little less intense or shorter duration exercise. But still the principles are the same. But I'm glad you brought that up. Those are things that we have to learn as we mature, right? All of those.
That's right. So I think one of the things that, a lot of parents worry about, at least I did, is multiple concussions, right? So particularly, obviously, if you have an athlete that's in a sport where they're a higher risk, what do parents need to know about multiple concussions? And does having one concussion put you at risk for having another?
Having a concussion can increase your risk of future concussions, most certainly within the immediate future from that concussion we're talking about. So I think...
Why is that?
Well, I think they're in this window of vulnerability. So once you get a concussion, I think the symptoms can resolve and they can have academic success and exercise success. But I do think for a period of time, they may just still be more susceptible. Certainly, if they're going to have a second concussion or a re-injury, it seems to be within the first 2 weeks of returning back to full participation. That seems to be the most vulnerable, if you will. Statistically, if they're going to have a repeat concussion, it's within that time frame.
Interesting.
And I do think there still exists some change in their personal threshold that probably goes down month to month and probably goes down to their own personal threshold at some point a few months in the future. Now, everyone has different thresholds. So there are some people that are just going to be naturally more susceptible to concussions, and they may accumulate concussions because they love a particular sport. And so we have to look and ask ourselves, how many is too many? Sometimes that is a real deep question that we have. Now, I will warn patients or parents to move away from an older model that says 3 strikes and you're out. I worry about that because if a patient or an athlete has had 2 concussions and they're back and doing well and they get hit during a game and they said, oh boy, I don't feel well, something just happened, but if I speak up, I'm going to be retired from the sport. I think I won't speak up. I think that becomes a dangerous situation.
Dangerous.
Yeah, because now we've sort of closed that really important line of communication. So each concussion has to be discussed. Repetitive concussions, as clinicians, we want to look at the mechanism. Is it getting easier and easier for this person to get concussions, right?
Yeah.
Is the third concussion where they got hit unexpected with a heavy collision? That's sort of a normal expected mechanism.
For almost anyone, right?
Right?
Yeah.
Or is it someone who says, I don't know, this time I fell on my bottom, I didn't hit my head, and I got all these symptoms. That would worry me because it sounds like a low energy mechanism, right? It sounds like that person is demonstrating a low personal threshold
to get a concussion with maybe a less severe injury.
Exactly. So that would get my attention. We would say, okay, what was the mechanism on each of the injuries? How far apart were each of the injuries, right? Were they 2 years apart or were they 2 months apart? And then we would look at how long it took to recover. Is the recovery on each of the injury getting longer and longer, or is each of the concussion recoveries what we would consider appropriate or average? Those are the features that go into saying, should I sit out for 6 months or a year or retire? And those are very heavy questions.
Yeah, I was going to say those are probably really complex questions to have with your care team.
Exactly, because there are times where we might be saying, look, I am not willing to clear you. And it's not common, but I've had those conversations. And that means we're taking autonomy from the patient or the care team, the whole family, right? And saying, I think you should retire. That is a huge deal to retire from their passion of lacrosse or football or soccer. It feels like and if they have that discussion, it feels like a big loss. It really needs to be processed carefully.
What are the risks of multiple concussions in sort of patients that you recommend retiring?
In those patients, they may have prolonged symptoms that they had during the concussions. They may have more either new onset recurrent headaches or persistent headaches, vision problems. They may report subjectively that they have more difficulty with concentration, memory, or vision. So those are all concerning in any person, but certainly in student athletes where so much of it is reading, studying, retention, immediate recall, delayed recall.
Important functions that we need to be able to do as becoming an adult.
Exactly, yeah, for sure.
So that's important. Well, so it sounds like, from minor to more complex patients, having comprehensive care for athletes at risk of concussion is really key. Can you tell us a little bit about how concussions are cared for here at Boston Children's?
Yeah. So particularly in prolonged cases, which is a large percent of what I see, because pediatricians are doing an excellent job in the community and they're caring for now, I think, what we might consider standard concussions well. If that patient's not recovering, they're going to probably seek out more advanced care or expert care. So I'll see a larger percentage of prolonged or complex concussions. Now, and sometimes I'll do my exam and I'll see that their typical symptoms may be headache and also balance, or headache and visual, or headache and cognitive. And in those cases, I may ask some of our colleagues to be involved, including our vestibular center. It's run by otolaryngology, or the ear, nose, and throat department. And so they may do vestibular testing.
To look for a balance?
Exactly. Look for balance and look for vestibular injury. Vestibular system is the complexity between visual input, the middle ear, the cerebellum, and spinal cord, do objective measurements where we watch the eyes with the video goggles and turn them and watch their tracking. We may also include neuropsych evaluation that helps us define and quantify immediate memory, delayed memory, reaction time, or cognitive function, brain function per se. And they may also help with defining or requesting more specific accommodations from school. So that's often a big help for complex cases. Physical therapy I call on quite a bit, not only to help with recovery of balance, coordination, vision, but also help with occipital neuralgia or pain and tenderness from the scalp, the neck, things that may come along from an injury that are slightly different than brain injury, but adding to the symptom burden overall.
The benefits of having a multidisciplinary approach, getting all of those experts to help manage symptoms and prevention and overall treatment is just, it's invaluable. And so it sounds like you have a great team of colleagues that get to work together.
Yeah, and I learn a ton from them. Each time we have a different case, they're all so unique, so I end up learning from our colleagues too.
You mentioned this very comprehensive multidisciplinary team. What about mental health, right? Because I imagine there's a significant burden on kids when they're dealing with the actual treatment and maybe being out of their sport for concussion.
Yeah. In our sports concussion clinic, in our division of sports medicine, we've actually recently added a few more colleagues because it is such a high demand. It's such a complex condition. And in prolonged recovery in particular, it seems like it's common to need that additional support from psychology and sometimes even psychiatry. But we have that in place. We're continuing to try to increase our colleagues the access to it because it's so important.
I just love that. When we can provide that multidisciplinary care and bring it to patients, then there's less gaps in care, which is great. Yeah,
you're so right. We want to have the best experts for each part of this. I never want them to feel like we're pushing them to some other specialty. I want to make sure we're part of a team together, and I'll typically continue to try to be the center of that team. We're going to find the resources, we're going to make decisions and make activations.
That's great. That's really great. Yeah, so I mean, I imagine too for some parents, maybe it's just me because I don't have contact sports players, but you may not really intuitively know that you should seek help from a multidisciplinary sports program like what we have here.
We have other colleagues too. In sports medicine, we'll be the ones seeing those patients that had sports-related injury, and non-sports-related injury they may be seen by our colleagues in neurology and the Brain Injury Center.
So another center for those kids that have concussion from a non-sports reason is really important too.
Yeah.
Like my kids that they had. Yeah. This is all really helpful. How about prevention, right? Because obviously no matter what the situation is, we want to prevent injury from our kids. Yeah. What things can parents do to help prevent injury?
Yeah, so the typical first response from parents is to saying, well, what equipment can I get to just fix this and prevent it and stop this from happening again? Unfortunately, that's been disappointing in the sort of the whole approach to concussion. Helmets are good at what they're designed for. They're mainly designed to prevent skull fractures and intracranial hemorrhage, and they do a good job at that. Face masks are good at preventing dental injuries, facial injuries, but neither can really prevent concussion, especially as we start thinking about the rotational acceleration, as we talked about in the beginning. The helmets can absorb impact, but they can't typically prevent the full rotational acceleration. So especially the unexpected hit where there's a rotation component to it, that can still create injury even with the helmet. Custom mouthpiece is also disappointing to say these have not been shown to really significantly prevent concussion. We'll keep looking at different equipment and say, well, can we find something that does work effectively, and then we'll all celebrate that when we find it. Other methods that are less tangible but have clearly worked will include some of the strength or prevention strategies we do at the McKaylee Center, as we talked about. Body control, general neck strengthening. Leagues changing rules and enforcing rules has definitely worked to reduce concussion rates. So you'll see hockey has different rules about boarding, checking next to the boards. That really prevents neck and concussion injuries, especially when the rules are enforced or when they're followed by the players. kickoff rules in American football have been changed, and then we can watch the concussion rates go down. I think very important to really think about what works well.
What you're saying in terms of strengthening and conditioning really fits with the mechanism of injury, right? It reminds me from a previous conversation we had on sports here in this podcast is that, maybe there's a need for kids to also practice other sports to help build just general, musculature and strengthening and balance, using muscle sets in a different way to help you prevent injury. Is that something you would say is helpful?
I do think so, yeah. Especially young kids. We want them to explore. We want them to be well-rounded. We want them to have general body control rather than just excellent performance at one small skill set. I do like the idea of cross-training or exploring new things, but there is early specialization.
Yeah. Literally having this conversation with my son right now.
Yeah, sure.
I keep trying to encourage him to do swimming and other things to build up his, his core. And I'm telling him it's going to help him with baseball and other things. And, he's like, baseball.
That's his passion, right?
Yeah. Right now.
Okay, yeah, it changes.
It does change a little bit, so that's good.
Yeah.
Well, I'm thinking as we get near the end of our conversation here, we've learned so much about prevention and treatment. Where are things from a research perspective in the world of concussion right now?
Yeah, you could think of it in a few categories: diagnosis, and treatment, prevention. I think those are the three big pillars. Diagnosis is still largely subjective. We're asking just about symptom scores. And I do look forward to the future where there's a bit more objective testing. It's like what are called biomarkers. So these are specific proteins that will be discovered only in the presence of concussion or brain injury. And we might be able to test them in saliva or finger sticks or even urine tests. And so biomarker research is being done right now. It's not yet in clinical practice, but I have hope that that'll help clarify who is injured and when are they truly recovered, and that will be objective testing. Treatment, I think our changes in treatment have been, in the last even 5 or 6 years, a clear answer in research that says early activation of light to medium non-contact exercise is actually beneficial. Not only is it safe, it's actually beneficial, more beneficial than dark rooms sitting on a couch. Early activation, early reentry into school with accommodations is actually beneficial. So again, back to the idea of preventing deconditioning, getting it back in the routine. Adding physical therapy, adding what we call vestibular therapy in physical therapy. That's been an additional tool in our treatment evolution. And then as we touched on just briefly a few minutes ago, prevention, maybe it will be equipment changes, but right now we're working on improving the athlete's balance, body control, and for creating and enforcing rules that prevent all the athletes together. And each of those is involving science.
We've come so far, right? And hopefully in 10 years when we're doing this podcast again, we'll be saying, we've got this biomarker and we know what things we need to do to prevent.
Exactly. We've cut the risk in half, and that will be beautiful when you invite me back for that.
I look forward to it. Because so many of our kids are involved in sports and it's so great for them. And now we just want to figure out how to best support them.
Yeah, in so many ways. It really is helpful. It's hard to deny the value of exercise, certainly, sports in addition, but we want to make it as effective and safe as possible.
Yeah, absolutely.
Yeah.
Well, Dr. O'Brien, we've talked about so many great things. Is there anything that we haven't talked about yet that you want to make sure we cover today for our audience? Learning
when to speak up and have autonomy for yourself, but also building the relationships, especially with coaches or colleagues or athletic trainers or parents who may be older than you as an athlete and in a position of authority, but being able to speak up and have that open communication. When it comes to identifying concussion and recovering from concussion, it really, that's essential. That the clinicians, the trainers, the coaches can't really do our job effectively and can't help take care of you as an athlete unless we have that open communication. That's a big part of it. If there's any teens and kids listening out there, or the parents can reinforce this, that it's only going to help them be the best athlete they can by having that open communication. Well, now it's my favorite part of the show. Doctor's Orders is that time where you give a prescription to parents to help them raise healthy and happy kids. So, Dr. O'Brien, what are your doctor's orders? That's a great question, and it's a really nice opportunity for me to put something out there. For organized sports participation, I think it's a good opportunity for the parents to be engaged, to be involved. But also when the athletic trainer or the coaches says, wait a minute, I think we got to take our player out because I'm concerned about them being injured. I think the parents have to support that decision and make it clear to the student athlete that I'm on board with this too. The coach or the trainer had a concern. I'm in agreement with this of taking you out. We're going to sort this out together, and we're going to be better and stronger for it later.
A really powerful prescription, really, for us parents, right? To make sure that we are, listening to the coaches, listening to our kids, and creating that safe space to support our athletes. But being a partner, right? It's kind of like...
Yeah, I think that's a good way of putting it. Yeah, being a partner and being involved and making a commitment together.
Well, thank you so much, Dr. O'Brien. It's been really great to chat with you. Thank you.
Thank you. Yeah, one of my favorite subjects, so thank you for having me here.
Thank you so much, as always, to our guest expert, Dr. O'Brien, and our guest parent, Mia. If you, like me, want to learn more about concussions, please check out our website at bostonchildrens.org. Until next time.